Today I will be talking about the fusion which we commonly do posteriorly in MIS TLIF open surgery. So for the end point, for everyone wants a good interbody fusion. So various techniques for our past so many years we've been minimalizing the collateral damage, and you see the more the bigger incision, the more the tissue damage and collateral damage. So we want to reduce that collateral damage, so that various techniques have been followed. So it's my own evolution, started with open surgery, then MIS fusion. I was happy with MIS fusion, but still there was some problems with MIS fusion. So I learned transcambian fusion. So then the posterior fusion, then we modified this posterior endofusion with a small changes. We call it as A-SERF technique, which is Asian spine endoscope en bloc resection of facet, which I will tell you shortly. So everyone knows about these advantages, disadvantages of the scopy now. So the advantages are more than disadvantages. This is the best part I like because of the mobility. So you can go cranial caudal with a single port. You can go medial lateral, and the reach is best with the full endoscopy posterior approach. With the clarity is the most because of the irrigation. So there are various techniques people follow. That commonest being the transcambian and posterior approach. Posterior, again, there is a lot of confusion in the terminologies. Some people say interlaminar approach, some people say translaminar approach, some people call it as transfacetal approach. So better to keep it simple. So just a posterior approach is enough. So the technique what we use is just extra at the time of insertion of cage. I use the screw port as for the cage insertion. The screw port which we use for the placement of screw, that screw port in the end of our surgery we use for insertion of the cage. So there's enough literature saying that endoscopic TLIF has a lot of advantages, either being a monoportal or biportal. So endoscopy scores over all the techniques available today. So enough point. So in our technique we have the entry point. Entry point we have given the name called Su point, where it's a junction of lamina, facet and the pars. So that junction is the one where we take a entry or mark the entry. So this point gives us the parallel entry to the disc space. So this is en bloc resection of facet. We call it as A-SERF technique. So the idea is to remove this. So idea is to remove the entire bone here. This is the bone we want to remove. The advantages being you get more bone for the graft. As we get in open surgery or MIS TLIF, we are getting more graft here. So removing the facet, after that we can remove the tip of SAP also, clearing the corridor for the cage insertion. So this is amount of graft. So we usually pack 6 to 8 cc of the graft as we do it in open surgery. So once facet is removed, we prepare the end plates, remove the beauty of posterior approach is you can do a good disc clearance for a better graft placement as anterior as your anterior annulus. Once pack the graft, you can see again there is a doubt that will this graft float out or this saline causes any hindrance. There is immediately after placing the graft, you can see a nice hematoma covering the graft, and it doesn't come out because it's not too much thin or powdery. So it's a patient's own autograft, so you need not worry about it. Once graft is packed, the biggest advantage of this technique is the cage insertion is visualized. You are seeing what you are inserting, your root is protected, and you are inserting the cage. You are absolutely sure that you are not injuring the root. This is the end point. So I'll just go through a small video so you can see how it's done. So we are here standing on the left side here. So the left side of our screen is cranial. So just once you land there, expose the lamina. So what I'm doing here is I'm just drilling the spinolaminar junction here first. So this is a spinolaminar junction. I'm just decorticating the bone so that later we can use the chisel better. So this is a laminospinous junction. Then this is the cranial part of the lamina. Say this L4 lamina. So I'm just, so that's a cranial part of the lamina. So I'm giving a cut on the lamina now. So it's same like open surgery or a MIS surgery. You give a cut here on the lamina. So I'm just giving a cut on the lamina, just decorticating. Then this is the pars. You can see the pars, this is isthmus of the pars. So I'm just drilling now the pars here. So once this cortical bone is a bit drilling is done, so that we can easily chisel it out. The entire bone with entire joint, the facet comes out. So I'm using specially my designed chisels. These chisels were designed by Mahesha, so which are very, very useful. So I'm just using, my assistant is helping me. So I'm just chiseling it out. So there is no fear here, because you know you have a control, and just go gentle tap. You need not go through and through. Once you have done a 2/3 bone is chiseled out, you just rotate it, it just breaks. So here I'm just chiseling out the part. So the idea is to have a bigger bone, bigger chunk of graft, so that fusions are always better. So you can see now I'm just twisting the chisel. That's the epidural fat you see. So then you can just coagulate this small blood epidural vessels here. Then now I use this curette and use it curette just to lift the bone. So that's the vessel, blood vessels. I'm just coagulating the epidural vessels. You have all the time you have control because of the saline irrigation. Now I go to the joint below, which I have already dissected it out. With the curette, I am just lifting the bone. So you can see the entire bone started lifting up. So once this entire bone is lifted up, so as a beginner you need not worry. Always you can make it 2 pieces or 3 pieces and remove it. So need not struggle initially. So once this is entirely floating, then grab with a tooth punch, heavy tooth punch. So you can see I'm just checking whether it is attached anywhere. So it's not attached, it's floating now. It's floating now. So I just grab it with a tooth punch. You can see I just came out just from the subcutaneous space. With the same incision, the 10 mm incision, you can remove the graft roughly about this. Once it is removed, rotate the sheath and then just use a chisel to open the window. And same the open surgery instruments, I just prepare the end plates and rest of the cartilage which is left out and prepared. This is endpoints, and I pack the graft with same open instruments or MIS instruments. You see the graft which we are placing, it's almost same, but this is the important part. Once the scope is in situ, I use the screw port which we will place for the screw, just dilate the tract so that I can place the cage without any muscle trauma. So I am seeing the thecal sac. This is a cage has been inserted, and my assistant protects the root. So you can see always the thecal sac or root is protected, and you insert the cage and it goes inside. So all the time you are seeing what you are doing. So having all the advantages of monoportal technique without any much muscle trauma, you only at the end point you use a biportal technique here. So just take the advantage of the screw port. So I just go through some examples. So in our own experience for past 2 years, we've been doing this technique. 108 patients, almost equal, male and female. So predominant back pain, and the We had one cage back out. Patient had aseptic inflammation and had cage back out. We went through the same incision and just removed the cage. Two port site infections and one epidural hematoma, which was again addressed endoscopically. These are few examples. You can see severe stenosis with listhesis. It is a very good technique where you can address the stenosis bilaterally, at the same time you can fuse it very well. Again, any type of listhesis you can address easily. This is a graph which I was showing. You can use expandable cages. Grade 2 listhesis you can very easily do. We are doing now grade 3 also. There are some difficult cases like this. It was a fixed listhesis with severe foraminal stenosis. So we did last 3 days back. So there is a severe stenosis at the same time. So this is a very good case. You can do a good clearance of the foramen with this one. So this case, again the people try transcambin here, they miserably fail because you can see that the depth of the L5S1 space, so it's very deep. So here it's again transcambin becomes difficult here. So you can achieve very good results with the posterior approach. 2 level, 3 level, very easily it can be done. You get as much as graft possible, no synthetic graft used here. And this just to show, always people ask me with saline irrigation, are your fusion rates good? Yes, definitely this is a traversing route, exiting route, and you can see the cage. Once you stop the saline, the beauty of saline irrigation, you see that the saline has stopped. The moment you stop the saline, field becomes last slide. So that's the thecal sac, that's the exiting route, traversing route, and that's a cage. So definitely there are limitations of a learning curve which we are struggling very hard to reduce the learning curve for the beginners. Cost is always there, and recurring cost, yes, that's an issue to nowadays. And training, I always quote this E-Spine Academy slide. So training should be always structural, the structure should be there, otherwise there will be a lot of confusion regarding training. So definitely the conference is all about discussing the future. Thank you.